So patient age 54, he lost all the teeth by periodontitis, and the first 1 year he is wearing denture. That leads to, both this condition lead to severe atrophy of the maxilla, both in the width and in the height. So we will plan how to plan this case, even though it looks like there is good bone, but the height is very much compromised. Even the pterygoids are looking challenging. First we will see the right pterygoid as usual. So this is the anatomy of the right pterygoid. Crest of the ridge, sinus expansion, very much distal. We can see the very wide radiolucent pattern here. That is a descending palatine artery, which will come out as the greater palatine foramen and artery. Here it is too much close to our target area. So the more vertical you are placing, the more you are into the canal space, descending palatine canal. So this is a descending palatine canal. We'll see. Yeah. So if you do the 360 degree, at one point of time you will see this descending palatine artery coming down, and it is exiting as greater palatine foramen. Sometimes this descending palatine artery is very close to our target area. Sometimes even it is difficult to avoid this structure. So some doctors, they plan to avoid this structure. That is one option, and sometimes it is not at all possible to avoid this structure. Sometimes you have to invade that, but that is not a issue. You will see some bleeding from the drilled area. You can place implant and you can solve it, but do not place implant too much into the descending palatine canal. So if you see here, if the implant tip is closer to this triangle part of the radiolucency, you will be into the descending palatine canal. Okay, so what you have to do is you have to increase the distal angulation. So now we increase the distal angulation. Even then you can see this is the descending palatine artery. If the drill goes here, you will see the bleeding from the drilling site. So what we are doing is we are tilting some more. So pterygoid, the more vertical it is, the more the risk of going into descending palatine. So if we change the angulation more distal also, the descending palatine artery is becoming closer. So that is the challenge of this pterygoid. This is anatomical variation, because the more distal you are angulating, the less risk you are, but for this patient it is. So now only we could able to avoid. Now only we are seeing the lateral pterygoid and the medial pterygoid, and this is the greater palatine foramen. But the angulation becomes very much distal. Now we are completely safer, around 16 mm. This is the greater palatine foramen area, this is the medial pterygoid area. But the challenge is you have to place very much horizontal now. So if you can see, so this is very much horizontal compared to the left side. You will see the left side now. You can understand the difference between right and left. So this is the left side. So this is the left side maxilla, distal maxilla. Sinus expansion distally. This is a crest. Very little space between the distal wall of the sinus and the distal part of the tuberosity. So which is a challenging situation. The less space here, the more challenging for the operator. Okay, so this is the ideal angulation. This is our target area. So we will see the cross section now. Now this is the cross section. So what are the challenges here? Buccolingually it is deficient. It is very thin. The buccal part is missing actually. It may be due to the long-term mobile periodontally involved 8, or during 8 extraction the buccal plate might have fractured, something like that. So we have to start the drilling labial or buccal to the crest. That is the trick here. So this is opposite to palatal approach. This is buccal approach of pterygoid. We will check the various angulation. So little more distal angulation. We are into the pterygoid fossa or into the medial pterygoid. The challenge is here is not the descending palatine artery. Only when we are going very much vertical, you are entering the. So this is the descending palatine artery, exiting as greater palatine foramen. In case during surgery unknowingly if you enter this space, that is not a worry. Select a shorter implant, and the moment you place the implant, the bleeding will stop. So better to take IUPA during the drilling stage and engage the correct part. So the more higher we are engaging, the more risk of descending palatine. So this will be a correct angle which we can confirm during the drilling area. So the left side descending palatine is not a major challenge. So here, see here, the more horizontal we are going, the descending palatine is in trouble. But the moment we just change the direction a little bit, we are in the safe zone. But if you compare the right and left, only the right side is more horizontal. Only at this angulation we can able to avoid the descending palatine, but on the left side we can easily avoid the descending palatine because anatomically it is far away from our target area. So this is a rare situation in which the descending palatine artery is close to our target area. So again coming back to the left side, the challenge is not the descending palatine, the challenge is the buccolingual width. So some part of the implant may be exposed on the buccal area, that is okay. And another challenge is the very thin. So if you place a 4.2, everything will get smashed up. So if you go for Norris Terrifit, the only diameter available is 4.2, which is a limiting factor in using Norris Terrifit for this kind of thin ridges. So use a very thin diameter implant, say 3.3 or 3.5, something like that. Either Neodent 3.5 or JD Pterygoid 3.3. You can use for safety, otherwise the alveolar bone will mash up, the tuberosity will mash up, will crack. Now we are leaving the pterygoids and we are going for the premaxillary implants. Our tentative plan is 2 tilted and 2 axial. We will finish the axial because they look easier. So axial is nothing but just lateral to the nasopalatine canal. This is the nasopalatine canal. This is the nasal spine, nasal floor, inferior concha, So the plan is simple. Once you open the flap, identify the nasopalatine foramen severe, then now just lateral to the nasopalatine foramen, drill bilaterally. Make sure you are not going into the canal. Okay. So when we place the implant, it was like this. It is like this. The bone is very much atrophic. The height is only 11 mm and the width is 3 mm. So if you place the implant from the crest, there won't be any bone in the labial side. So we will be planning a palatal approach. Okay. So palatal approach you can do parallel to the labial. You start the drilling palatally, but keep the drill parallel to the labial aspect. This is one type, but the drawback is it will come more palatal. So what you can do is a slight palatal tilt. You will get the abutment in a correct position. That is the trick for palatal approach. So we will be using there is no need for any alveoloplasty here. Already bone losses are maybe 3.75, 11.5 or 12 mm implant will be fine. Very thin diameter implant, of course, 3.3 or 3.5 something. This is the right side axial. The height available is 11. The width is around 2.9. So going from crest is not advised. So we are going from palatal approach. Okay, this is the correct palatal approach. We can go towards the labial also, from palatal towards the labial, but you will get the abutment more palatally may interfere with the tongue space. So this small trick we can bring, we can change the palatal positioning of multi-unit abutment into labial. Very short implant, thin diameter implant, 10 mm. Here it is only 10 mm. So the challenging part is the tilted part. So we will try to place an axial implant. So this is in the first molar area. The bone is highly unfavorable. It's only 6 mm. Now we will try the second premolar area. Second premolar area, the height is around 9 mm. The bone width is also 1 or 2 mm. Now we will go to the first premolar area. Just in the first premolar area, we are getting this pillar here. It is the nasomaxillary buttress or canine column. Yeah, the bone is little bit increased towards the buccal aspect, not on the palatal aspect. Still towards the palatal aspect, the bone is 7 mm only. Maybe if we go abutting the labial aspect, you may go 11 or 12 mm. The two not great. Now we are going to the almost in the canine area. Canine area is nothing different. The height is 7 mm. Towards the labial maybe 11 mm. So height wise it is very, very challenging. So we will try the tilted option from second premolar. We will tilt mesially. Even if you tilt mesially, it is the same. There is no much difference. If we drill palatally, that's it. We will be placing only 6 or 7 mm implant. So we have to be careful coming towards the labial aspect. Some part of the implant may be exposed towards the nasal floor, that is okay. Maybe 12 mm implant we can place. So highly challenging situation. Left side is also very similar, but actually more worse. This is the first molar area, absolutely less bone. We'll go to the second premolar. This is the left second premolar, only 7 mm or 8 mm bone. So what we will do is we will tilt the second premolar implant towards the buttress, but still it is around 13 mm. If we tilt towards the nasal floor, 8 mm. So if we angulate towards the buttress area, that is towards the buccal area, we may get a little longer, but the abutment positioning will be more on the palatal aspect. So it is a challenging situation when considering both the pterygoids. The right side pterygoid challenges descending palatine artery, left side pterygoid challenges buccolingual width. The tilted implant challenges very less